Hello, I'm Gail Malone, Director of Global Clinical Education and Key Opinion Leader Management for the restorative and preventive businesses of Dentsply Sirona. I'm also a clinical dental hygienist and former dental hygiene educator. It's my honor and pleasure to bring to you this overview of the fundamentals of ultrasonic technology in preparation for the upcoming training sessions at your university. As we go through the program, I'll address the following key areas: the fundamentals of ultrasonic instrumentation, both piezoelectric and magnetostrictive. I'll speak to the modes and the mechanisms of action of ultrasonic scaling, and we'll briefly look at system performance enhancements and harmonious systems that are specific to the Cavitron systems. Lastly, I'll highlight the importance of tip performance and tip selection and some ergonomic considerations. So let's get started. As we look at the fundamentals of ultrasonic, we know that ultrasound is anything above frequencies of audible sound. This is generally anything above 20,000 hertz. As you can see, we have low bass notes at the very low end of the scale, and things like diagnostic and non-invasive diagnostic evaluations at the very high end of the scale. Dental ultrasonic scalers are at the low end of the ultrasound scale in the 30,000 range. At that very high end, with diagnostic imaging, we have high frequency waves that have the ability to penetrate soft tissue, but they bounce off harder tissues, things like organs, bones, and teeth, and then send a message back to the transducer. This message is then interpreted as an image of the patient's body. So the frequencies used in diagnostic ultrasound at that high end of the spectrum are typically between 2 and 18 megahertz, significantly more than the 30,000 cycles per second that we use with ultrasonic technology. The ultrasound technology at the higher level that you're probably most familiar with is in the form of ultrasound used to monitor things like fetal development. There are two basic types of ultrasonic technology. We have magnetostrictive and piezoelectric. This image provides a visual of the basic differences in terms of functionality of the two technologies. On the left side, you see an image that demonstrates how magnetostrictive or Cavitron technology works. With this technology, we have an electrical field that's generated inside a coil in the handpiece. That creates a magnetic field. The magnetic field then excites the metal stack of the ultrasonic insert that's placed inside the handpiece. When that stack is excited, it expands and then contracts to its normal length, and that causes the tip to vibrate and move back and forth at approximately 30,000 times a second. With piezoelectric technology, we apply voltage to ceramic crystals that are inside the handpiece. We do this by adding the voltage and then subtracting the voltage, and in doing that, we essentially do the same thing. We excite a crystal, not a stack, but a crystal. And that crystal will expand and contract with those vibrations, causing the tip at the end of the handpiece to vibrate or move at 30,000 times per second. The first magnetostrictive ultrasonic scaler was released in 1957 by Cavitron Dentsply, and the first piezoelectric ultrasonic scaler was released in 1970 by the Satellat Company. Magnetostrictive materials can be broadly defined as materials that undergo a change in shape due to the change in the magnetization state of the material. It was in 1842 that James Joule recorded the shape change of nickel due to a magnetic field. Here you see a list of some other magnetostrictive materials, things like iron, nickel, cobalt, terbium, dysprosium, and some associated alloys. The ultrasonic stack in a Cavitron ultrasonic insert is made of something called permanickel. It's a nickel derivative with iron particles and also some chrome. At the very molecular level, magnetostrictive materials have lattice structures. The lattice structures are held together by polarized electron clouds of molecules. The magnetic fields distort the electron clouds, allowing domain alignment and shape change of the material. This little video graphic that you see here is a good visual for understanding how this works. When we add and subtract the magnetic field to the stack, you can see that the poles on the particles are changing north and south. Kind of like when you were in primary school and you were playing with magnets and you had a north and a south pole and you could move them around by moving the magnets. Remember doing that? We're doing exactly the same thing. We're changing the poles in the material, and that causes the stack to expand and contract. And that as that length of the stack changes, it creates mechanical energy, and that mechanical energy is what causes our tip to vibrate. Now, this next slide is a short video, and it features one of our longtime research and development engineers, Ken. Ken has a long history of working with ultrasonic devices, particularly with Cavitron systems, and he's going to provide some further information on this concept.
Today we're going to talk a lot about vibrations, and an important concept to understand is what's called a longitudinal wave. And I brought this demonstration. This spring is experiencing a longitudinal wave. It's very much like what happens to the permanickel stack in the handpiece. A magnetic field excites the permanickel and imparts a longitudinal wave at ultrasonic speeds, and that vibration in the stack is extended out to the tip.
To better understand how magnetostrictive technology works, it's helpful to understand the anatomy of a magnetostrictive insert. With an ultrasonic insert, there are several components that make the actual complete insert. We have a stack at the back, and that's made up of the thin strips of permanickel that we talked about previously. And we excite those stacks with a magnetic field. Then we have a connecting body, which is actually an acoustical amplifier. It takes the energy from the stack and it amplifies it up and then transmits it to the tip. There's also a nozzle that goes over the connecting body, and that provides a channel that allows us to drive water across the stack. And then lastly, we have the tip, and these are available in various insert designs and shapes. So in summary, with magnetostrictive technology, electrical energy is applied to the coil within the handpiece, and that generates magnetic energy. The magnetic energy is applied to the insert stacked metal strips, creating mechanical energy, and that mechanical energy is what creates the vibration that exits from the working end or the tip of the insert. Very quickly, let's take a deeper look inside the actual handpiece of a magnetostrictive scaling device. In the cutout, you can see that there's a drive coil. That's that big blue arrow. Electricity is applied to the coil, creating that magnetic field, and that magnetic field will then entice or excite the ultrasonic stack of the insert that's inside the handpiece. That causes the stack to elongate and then return to its normal length, driving energy through the insert and causing the tip to vibrate. As the energy moves through the insert, there are nodal regions or areas that we like to call zero energy points, where there is no vibration occurring. You can see that in the video as it's vibrating. This is basically driven by physics, and there are certain key wavelength points on an ultrasonic insert that I want to point out. We use these nodal points to our advantage. There's one in the center of the stack, so that the energy on the stack is going left and right on both sides of that nodal point. There's also a nodal point in the middle. If you see that green dot at the middle arrow, we use that nodal point to actually hold the grip onto the insert so that it doesn't rotate or move when it's in place. And then finally, we have the most important nodal point, and that's the one that's towards the very end of the insert. Approximately 4 millimeters from the end of the tip is the last nodal point. Beyond that nodal point is the active area of the insert, the only part that is actually moving or vibrating. It's the working end of the insert that comes in contact with the two surfaces during our debridement procedures. This next video with Ken is a great visual for helping us to understand what those nodal points are.
Okay, earlier we discussed longitudinal vibration and how the stack generates a longitudinal vibration. That vibration travels through what's called a connecting body into the tip. The longitudinal vibration excites the tip, and the tip begins to move at ultrasonic speeds, creating a whipping action which generates a nodal point at the end of the tip. And I'm going to show you exactly what's happening to the tip as it's excited at ultrasonic speeds. The tip experiences those vibrations and responds with a whipping action that generates this point of no vibration out at the end, and that's referred to as a nodal point.
Magnetostrictive technology produces an elliptical movement of the tip. An elliptical movement is predominantly linear, meaning forward and back, but with a bit of what we call a side wobble. And that side wobble more evenly distributes the energy or the movement of the tip, allowing all surfaces to sweep against the tooth surface or be active. This includes the back and the face of the insert. And this is an important distinction and point of differentiation between magnetostrictive and piezoelectric technology. With magnetostrictive technology, all the surfaces are active and can be adapted to the tooth surface. With piezo, the two lateral surfaces are considered to be the active surfaces and the surfaces that are indicated for adaptation to the tooth surface. While all surfaces are active, they are not equally active with the magnetostrictive technology. The highest amount of energy comes off the very point of the tip. Therefore, we should avoid direct contact of the tip to the tooth, as it has the potential to cause gouging to the surface and/or patient discomfort. We can, however, use this to our advantage, this energy to our advantage, by engaging the tip to a calculus deposit to help microfracture the deposit and remove it from the tooth surface. But again, we should not engage the tip directly onto the tooth surface because of the high amount of energy that's exiting at that point of the tip. So that summarizes the overview on magnetostrictive technology. Now let's look at the other smart material that converts electrical energy into mechanical energy, and that's piezoelectricity. Piezoelectricity is the ability of some materials to generate mechanical motion in response to electrical potential. A great example of this is something that I'm sure all of you experience every single day, and that's something that's within our mobile phones. There's a piezoelectric device, and that's what causes our phone to vibrate when we have it on vibrate and we receive a notification or a call. That's piezo technology. Piezoelectric materials have a crystalline structure compared to the lattice structure of magnetostrictive materials. The crystalline structures are held in place by atomic forces. In 1880 was the first demonstration of direct piezoelectric effect by the brothers Curie. The brothers Curie was actually Pierre and Jacques, brothers to Madame Curie, who observed this. They noticed that when they applied voltage across certain materials, they changed in shape and dimension and generated a mechanical motion. Materials that exhibit a piezoelectric effect include the things that you see listed here on the screen: quartz, topaz, bone, man-made ceramics, and some plastic polymers. Now, with piezoelectric technology, electrical voltage is what causes the material to align and expand. Piezoelectric devices contain crystals, and when we apply voltage across the crystal and change it, meaning we increase or decrease the voltage, you can see that the crystal then aligns and expands, just like the poles of the magnet were aligning and expanding. And that causes the crystals to expand and contract, and the energy created by that expansion and contraction moves through the handpiece and exits at the tip, causing the tip to vibrate. Here you see a little graphic. The meter will show you that as the voltage changes, the crystals expand and contract, and this is the basic way that we drive a piezoelectric device. Here's the anatomy of a piezoelectric ultrasonic handpiece. Ceramic crystals are housed in the area just forward of the area that's labeled mass. On the image at the bottom of the screen, these are the light green parts that you see. They are under compression by the horn. And when electrical current is applied to the ceramic crystals or discs, they change in dimension, creating vibrations which are directed through the horn and the tip. The little gray bars that you see adjacent to those green areas are actually the electrical contacts where we apply the voltage, and that's what causes the discs or the crystals to expand and contract. The mass portion allows the energy to move forward towards the tip instead of going in two directions, meaning backward and forward. So the mass essentially forces the energy towards the tip, and then the horn is actually, again, an acoustic amplifier similar to what we have with a connecting body in a magnetostrictive insert. And that directs the energy towards the tip. And then you have various tip designs for various levels of deposit and areas of the mouth. With a piezo device, we also run water through the very center of the device. And as mentioned earlier, with piezoelectric technology, the two lateral surfaces are active surfaces. And those are the surfaces that we adapt to the tooth surface, compared to magnetostrictive, where all surfaces are active and can be adapted to the tooth for debridement procedures. Now, this slide completes the overview of the fundamentals of the two technologies. In this next section, we'll briefly review the considerations for using ultrasonic devices with patients who have implanted electronic devices. So this is $1 million question. What about using ultrasonic devices or scalers to treat patients who are fitted with implanted electronic devices, things like pacemakers, defibrillators, and other types of electronic devices? As you can see in the slide, there really is no clear consensus in the literature. There's actually conflicting information between dental scientific literature and pacemaker device manufacturers. From a Dentsply Sirona position, this was specifically called out in the IFU, or the instructions for use for the device. And we recommend that you always check the IFU for the device that you are using regarding the recommendations for the use of that device on patients with implanted electronic devices, because they are not all the same. And as you can see, the statement in our IFU says that although no instance of interference has ever been reported to Dentsply Sirona, we recommend that the handpiece and the cables be kept at least 6 inches or 15 centimeters away from any device and their leads during use. There are a variety of pacemakers and other medically implanted devices on the market, and clinicians should contact the device manufacturer or the patient's physician for detailed information about that specific device. Now, we defer to your institutional and national guidance and policies on this topic, but I share with you as a point of interest some of the studies that have been published on this topic. What you see here is a study that was published in 2015 in the Journal of the American Dental Association. And it's actually a very important study because it was the first in vivo study regarding pacemaker interference with ultrasonic technology. The conclusions of the study found that electrical devices commonly used in dental practices do not interfere with the sensing and the pacing of contemporary cardiac patient pacemakers, or what we refer to as ICDs. However, they do interfere with the telemetry from the cardiac programming unit, which is not found in the dental office, but rather at the pacemaker monitoring facility. But that interference has no impact on patient safety. The authors state that these findings should help in the development of clinical guidance regarding dental management of patients with pacemakers. And regarding the practical implication, the authors of the study states that overall dental devices do not appear to interfere with pacemakers and defibrillator pacing and sensing functions. So what do the manufacturers of these implanted medical devices say? This is from the Medtronic website, Medtronic being a leading manufacturer of these implantable devices. And as you can see, they state that if the device is used as intended and it's in good working condition, there are no known risks to all of the things that you see listed here, and dental ultrasonic scalers and cleaners are circled. St. Jude's Medical, another leading manufacturer of these implantable devices, actually calls out Cavitron by name, stating that the Cavitron brand ultrasonic cleaner has been used on pacemaker and ICD patients uneventfully. Goes on to speak to the fact that the ultrasonic transducer, meaning the working end and the cabling, should be kept at least 6 inches away, 15 centimeters, away from the implanted device, and any associated cord should not be draped over the patient's chest or near the site of the implanted device. Now, as I mentioned earlier, you always want to check the IFU for the device that you are using. Here's the current IFU, or as they say, directions for use for PAs on device. And they specifically do call out that ultrasonic oscillations may prevent cardiac pacemakers and defibrillators from functioning properly, and state that they recommend that patients with cardiac pacemakers or defibrillators should not be treated with the PAs on devices. So again, always check the instructions for use for the device that you are using, because they are not all the same based on the testing from that particular manufacturer. And lastly, we know that implanted electronic devices go beyond cardiac devices. This is an older study from 2002, but it discusses the effect of dental equipment on a vagus nerve stimulator. And as you can see, the conclusion stated that a Cavitron at maximum power did not alter the function of the vagus nerve stimulator. So as I bring this around full circle to you, in summary, from a Dentsply Sirona perspective, and really just from a best practice perspective, always follow the IFU for the device that you are using to make sure that you're within the parameters of what that manufacturer recommends for using that particular device on patients who have these electronic devices implanted. So now we've had an overview on ultrasonic technology. We've talked about some of the considerations for implanted cardiac devices and some of the other devices on the market. Let's take a look now at the different modes and mechanisms of action for powered instrumentation. And these modes and mechanisms of action apply to both piezoelectric and magnetostrictive technology. Our modes of action for power instrumentation include mechanical removal, irrigation or lavage, as well as cavitation of the water stream. And our mechanisms of action are frequency and amplitude. And those mechanisms and modes combined are what contribute to the cleaning efficiency of the device that we are using. How efficiently a powered instrument removes calculus is determined by the frequency, which is essentially the vibration of the tip, and the amplitude, or the length of the stroke, of the working end of the powered instrument. It's also impacted by the design of the working end in cross-section, or the geometry, and the surface of the working end that comes in contact with the tooth surface. And we'll get into these concepts a little bit later, and certainly more during our hands-on session at the university. So let's look first at our mechanisms of action. As I mentioned, these include frequency and amplitude. Now, frequency is set by the manufacturer. It's a measure of the number of occurrences of a repeating event over a unit of time. In the case of Cavitron, the majority of the market is 30,000, 30K. So 30,000 strokes per second is the operating frequency. Older units operate at 25,000 strokes per second, or 25K. But most of the market today is in the 30K range. Amplitude is the magnitude of the change in the oscillating variable. Amplitude can be changed by adjusting the power setting on the unit. So it's that power setting that has the ability to increase or decrease the amplitude. Let's look at this a little bit more. Here's Ken again, going to share his thoughts on that.
Today we're going to talk about two important concepts, frequency and amplitude. I brought this bell to demonstrate both. Now the bell has a resonant frequency, a natural resonance based on its diameter, its weight, and its material construction. And that defines the frequency at which it would ring. If I strike the bell, what you hear is its natural resonant frequency. That's very much like the way an insert operates. When we excite the insert, it vibrates at its natural resonance based on its physical length and size. Now, amplitude is actually the volume at which the bell rings, and it's dependent on how much energy I put into the bell. So if I strike the bell harder, it actually rings at a louder amplitude, but the same frequency. And that's analogous to turning up the power on your Cavitron.
So as I mentioned earlier, the frequency of the device is set by the manufacturer, with magnetostrictive technology operating in the 25 to 30K range. And we see the same for piezo. While there's some units in the piezo market that do operate at a higher frequency, about 90% of the piezoelectric market operates at 30K or 30,000 cycles per second, similar to magnetostrictive. Ken used the analogy of the bell in talking about resonant frequency. Every insert has a resonant frequency, and it's around 30 kilohertz. They're not all exactly 30 kilohertz, and that's really because of manufacturing processes. However, they're very close to that. And as you can see on this chart, for optimal performance or maximum stroke, inserts should operate at their resonant frequency, the very top of the crest of the bell curve. This is where you're going to get the most efficient performance out of that particular insert design or tip. And this really speaks to the importance of using inserts and units that were designed to work together as a system. In other words, harmonious systems. Inserts and units from the same manufacturer will deliver the best performance. So we want to focus on keeping our systems harmonious, meaning don't mix your inserts from one manufacturer to units from another. It's going to have some sort of an impact on the actual performance of the inserts. Amplitude, as referenced earlier, is the measurement of how far the powered working end moves back and forth during one cycle. Higher amplitude is going to deliver longer, more powerful strokes, while lower amplitude is going to deliver a shorter, less powerful stroke. As Ken pointed out in the bell video, we can adjust the amplitude by adjusting the power setting on the power scaling unit. Now, if we look at this example of a child on a swing, low amplitude, as we see on the left-hand side, would be a gentle push against the child's back, causes that swing to move forward only a very short distance before returning to its starting position. Lower amplitude causes the power working end to move a very short distance with not a lot of energy. Compared to the example on the right, where here we see higher amplitude, and now the working end of the insert is going to be moving a much greater distance. So think of this as similar to providing a more forceful push against the child's back, causing the swing to travel a much longer distance before returning to its original position. One thing that you will note is that while the length of distance that they're covering with each swing, the number of swings from a timing standpoint remains consistent. So our frequency is the same, but we're seeing a difference in the amplitude. Power level is what determines the stroke length and how far the instrument tip actually moves during one cycle. The amplitude of the powered working end is adjusted by moving the power up or down. At the same power setting, different tip designs as well as different tips of the same design will oscillate with different displacement amplitudes. So what this means from a clinical perspective is that in order to achieve the same level of performance, different power settings are going to be required for different tips. Therefore, clinicians should expect to make adjustments to the power setting for the tips that they're utilizing in practice during patient treatment. A lot of times, this is something that's overlooked. We many times see clinicians taking a one-size-fits-all approach to power settings when in actuality, knowing what we know about the technology, we need to be adjusting that power setting based on treatment objectives, patient presentation, tips that we're using, a lot of factors that we need to consider. This is an example of showing how the stroke level, how power impacts the length of the stroke, similar to what we saw with the child on swing. For this demonstration, the frequency remains constant. So let's say 30K, just as we would see with our Cavitron devices, but it's the amplitude or the length of the stroke that changes with a power level. So the higher the power level, the longer the stroke, and the longer the power level, or the lower the power level, the lower the power level, the shorter the stroke. The lower power producing that shorter stroke would be indicated to remove light calculus, stain, biofilm, and endotoxin. Compared to a higher power, where we have a longer stroke, we're going to need that for removing moderate to heavy calculus and stain. Now, as you know, Cavitron technology has been around for a while, more than 60 years, but along the way, there have been some significant system performance enhancements that have been made. And let's take a quick look at what some of those are. The first is sustained performance, SPS technology as it's called. And essentially what this is, it's the ability of the system to sense the need for additional power and automatically adjust to that need so that the tip maintains the length of the stroke. So an example of this is, let's say the clinician is working and they have the unit set at a particular power setting, and that tip engages a tenacious piece of calculus. What SPS technology allows the unit to do is automatically adjust and provide additional power so that they can maintain the stroke against that tenacious piece of calculus. Sometimes we refer to it as cruise control for the handpiece. Another system performance enhancement is boost mode. You are probably familiar with this. Boost mode is activated by the foot control. It's a second position on the foot control, and it's only available on the newer units that have 30K technology. But essentially what this allows you to do is it allows you to boost or increase to a higher power level when needed by simply activating the foot control. It's hands-free, so as the clinician is working, you could essentially cruise at a lower power, if you will, and then boost to a higher power by stepping on the foot control only when needed to remove the deposits as they present themselves. Now this chart shows the impact of boost mode on the power level. And you see 3 different colors here. So let's start with the blue line. This is a magnetostrictive unit at what we call normal power. So you can see that the power increases obviously as we go up the scale, but it's not quite linear. There's an extended period within the lower power zones. This is what's referred to as the blue zone on Cavitron technology. And then you can see the yellow line, which is piezo technology with a clear linear path from low to high power. And that pink or magenta line demonstrates magnetostrictive technology in the boost mode. So at the lowest power settings, when we activate boost mode, we're going to get the greatest amount of increase in power. And then as we go up the scale, you can see that we still get an increase in power, but it's not as great simply because we're operating at a higher power from the start or to begin with. Another system performance enhancement is the tap-on technology. And this simply means that the one tap of the foot pedal allows the unit to be activated. It'll remain active for about 4 minutes, so you don't have to keep your foot on the foot control constantly during the procedure. It's also available for some of the prophy modes on the air polishing systems. So now let's go back and review our modes of action. We talked about the mechanisms of action being frequency and amplitude. Now let's look at our modes of action. First, we have mechanical action, and this results from the longitudinal sweeping motion and rapid movement of the tip. As we said earlier, the tip is moving at about 30,000 cycles per second. So in other words, in ultrasonic scaling, it's the working end of the tip that's doing the work and providing the power versus the clinician being the power behind manual scaling. The very rapid vibrations, those 30,000 strokes per second, create microfractures in the calculus deposits, and that results in gradual removal of the deposit. Another mode of action is lavage or irrigation. And this simply means that we have a stream of water that exits near the end of the tip. It comes through a water port, and this provides constant flushing within the sulcus, the periodontal pocketing. We call this fluid lavage. This water irrigation also plays a very important role in periodontal therapy because it has the ability to flush the base of the pocket and washes away any of the toxic products and free-floating bacteria from the pocket that were removed during instrumentation. Now, a sufficient amount of water flow is needed to minimize any frictional heat that's created by the tip against the tooth. And this is done by adjusting the water spray or the flow rate. And you do that by turning that blue knob at the base of the handpiece. You have the opportunity to do this and work with this during the hands-on session that we do at the university. I always want to make sure that we are using an appropriate amount of water to cool the handpiece, and this adjustment allows the user to select that appropriately. Keep in mind that decreased water flow produces a warmer water lavage, and an increased water flow produces a cooler lavage. But ideally, what we're looking to achieve is a nice mist with droplets as our spray pattern. And then for our final mode of action, we have the phenomenon of cavitation. This was first reported by Professor Damian Walmsley, a name I'm sure that's familiar to all of you. It was reported back in 1984, and it results when the water supply meets the vibrating tip and then forms minute bubbles. The bubbles grow in size, and then they actually collapse inward or implode. And when this happens, there's a release of microscopic energy, and that burst of energy has the ability or has the potential to disrupt the bacterial cell walls. It also contributes to biofilm removal. Now, this video was recorded in 2016 by Nina Baez, who is also from the University of Birmingham. And what you can see here is the video was captured at 90,000 frames per second. You're seeing it at 10 frames per second. But what you have is the free end of the video is actually vibrating, and you can see this point here is the area of the nodal point. Acoustic microscreaming is tied in with cavitation. It's the forceful flow of the cavitational fluids. It's the removal or the disruption of biofilm by these turbulent currents of water that surround the tip. And acoustic microstreaming actually enhances powered instrumentation effectiveness because it has the ability to clean beyond the surface that's actually being touched or adapted, or where the insert tip is adapted to. So if you look at this image on the slide, you can see A represents an insert that was being used essentially dry with no water. And then A plus B is where we're using the appropriate amount of water. And what we're doing is we're increasing the effectiveness beyond the area that actually is being touched by the insert tip. So that contributes to our effectiveness. Now, as mentioned earlier, Cavitron ultrasonic scaling systems work with Cavitron inserts as a system. They were designed and tested to deliver maximum performance for all of the currently available Cavitron branded ultrasonic inserts. So this is a harmonious system. The IFU for a Cavitron device includes a statement that here's what it states. Companies that manufacture, repair, and modify inserts carry the sole responsibility for proving the efficacy and performance of their products when used as part of the system. Users are cautioned to understand the operating limits of their insert before using it in a clinical setting. And this is very important in regards to tip wear. And that's what we're going to talk about here. We want to make sure that we are measuring and monitoring our ultrasonic tips for wear, because this can impact a number of things. So you can see in this image, optimal scaling area, as we're seeing on the left-hand side with a brand new insert. We're getting that long stroke, and we have an insert that is essentially brand new. The middle image shows us an insert that has been worn by 1 millimeter. So now what we have is a reduced scaling area. And then the last image on the far right, that insert is worn by 2 millimeters. And you can again see how our scaling area has been reduced. So a tip that's experienced 2 millimeters of tip wear has lost 50% of its scaling efficiency. In theory, as the tip wears from use, the distance that's traveled is significantly reduced, resulting in a loss of efficiency. Now, what happens is when clinicians use these less efficient worn tips, they intuitively compensate for the loss of efficiency in a number of ways. Many times the clinician will actually apply more pressure to the tooth surface while scaling because the insert isn't operating the way that they feel that it should be. In a comparison of an insert's ability to effectively remove deposits, a new Cavitron ultrasonic insert was compared with a Cavitron insert that had approximately 2 millimeters of tip wear. The result was a 30% increase in scaling time while applying approximately 40% more pressure or force throughout the course of the scaling procedure with the worn tip. Again, this has the potential to result in increased patient chair time as well as an increase in pressure.
Selecting the appropriate ultrasonic insert based on the type of deposit and anatomy can have an impact on scaling efficiency and comfort. Another key to optimizing performance is using a well-maintained ultrasonic insert. Did you know that the last 4 millimeters of the tip is referred to as the active area? This area is responsible for the removal of calculus and biofilm. As the tip wears from use over time, this lost length translates into a loss of efficiency. In this test, we compared a new Cavitron ultrasonic insert to a Cavitron ultrasonic insert with only 2 millimeters of wear. On average, the worn insert results in a 30% increase in total scaling time. In addition, a clinician will use 40% more scaling force over the course of the procedure. This may result in an increase in both patient chair time and pressure used by the clinician while scaling. What could you do with 30% more time? Check your inserts regularly to maximize efficiency and comfort for you and your patients.
So measuring tip wear is the most accurate measurement or the most accurate method for maintaining ultrasonic inserts. And as you can see, 2 millimeters of wear is a small amount of reduction in the total tip length. However, on a 30K insert, 2 millimeters of wear reduces the length of the active tip area by 50%. This is very difficult, if not impossible, to assess just visually, and therefore measuring is the recommended method of tip maintenance. We recommend that users evaluate and measure the wear of the insert prior to use. It's a very good habit to get into, especially for students, to develop this as part of their training and education. And we'll spend some time on this as part of our hands-on training when we're at the university. Now, tip shape options and designs will be covered in much more detail in our lab hands-on session, but I do want to provide you with just a brief overview of the various tip shape options. We have basically two categories, straight and curved. Obviously, the straight designs adapt to more of our flat anatomy, and our curved designs are there for our curved and more complex anatomy, particularly root anatomies in periodontal situations. Standard diameter inserts or tips, this is what we refer to as power lines, have the diameter, the tip shape, and the movement pattern that's needed to be effective against moderate to heavy deposits. There's a variety of tip styles available in standard diameter designs, and again, these perform optimally at the higher power settings. So these inserts, anything that's a standard diameter insert or a tip, is indicated for moderate to heavy deposits at a higher power setting. We're showing the magnetostrictive inserts at the top and then similar tip designs for piezo technology at the bottom of the slide. The thinner diameter inserts, referred to as modified or slim inserts, are indicated for the removal of plaque biofilm and light to moderate deposits in the smear layer. These inserts are approximately 40% thinner than a standard insert, and they improve our access in subgingival areas. The line of slim inserts includes a straight insert and then also actually two straight inserts and two area-specific curved inserts. Now, the power level indicated is the lowest effective power level to accomplish the task, which is generally in the blue zone, meaning that lower power setting. However, when we're using the lowest effective power, we always want to make sure that we're choosing the lowest effective power. So even though it may be low, we may have to bump it up to medium, depending upon the characteristics of the deposit that are present that we're trying to remove and debride. The thinnest, or the ultra thin insert, is shown here. It's 47% thinner than the current slimline straight, and it is uniquely usable at all power levels. So it enables great access in areas of tight tissue, into the interproximal surfaces, and on narrow root anatomy. We also stress that this insert is really ideal for preventive debridement in the adult prophylaxis patients. Excellent for biofilm disruption. Given the straight design, the subgingival use would really follow the recommendations in that it could be used universally in areas of healthy tissue, and it could be used as needed for gross removal of subgingival calculus, but limited generally to the anterior teeth when performing final root debridement. We'd want to focus on our curved inserts to meet the complex root anatomies that we have in the posterior areas of the mouth. We mentioned spray patterns earlier. Get rid of this. And when we have spray patterns, we always want to achieve that nice mist with droplets. And that's what you see on the right-hand side. Note that there is a slightly different spray pattern that goes along with the thinsert, and that's simply due to the location of the water port. But again, we want to have that nice mist with droplets, using just enough water to make sure that that tip is cooled. Ergonomics is extremely important, and there are some ergonomic considerations that we want to consider. There's the benefit of having a swivel cable or swivel component. It can be part of the insert design, or it can be built into the handpiece, and that's what you have with the Cavitron Dentsply unit. Depending upon the model that you're using, it's either in the cable itself or it's in the handpiece. The wireless split control also provides some nice ergonomic considerations, along with thinking about our cord management and how we're positioning that cord. And again, we'll address this as part of the hands-on session that we have coming up. This is the Cavitron SteriMate 360. It is available on the newest units. And what it allows you to do is to rotate the insert while holding the nose portion of the handpiece. So it essentially is effortless rotation while you're working. You can easily move it with your fingers, both rotating here at the handpiece or rotating here on the insert. So it provides a very comfortable user experience. Other ergonomic considerations include wider grips. We know that these are advantageous in lessening muscle load and pinch force, and that's exactly why the fit grips were designed. They were designed to help to minimize that muscle load and pinch force. And lastly, we have the integrated scaling units. It's the Cavitron units that can be integrated directly into the dental unit. They include Blue Zone and SPS technology and the flow water control on the handpiece, but it essentially uses the dental chair foot pedal for activation. So as I said, it's built right into the dental unit, so there's no additional foot pedal on the floor, and you don't have the tabletop unit. We see these in a lot of the universities, and I'm sure you have similar situations in your environment. So that really brings us to the end of our technology section. I hope you walked away with maybe a few things that were new to you. But just from a summary standpoint, we've covered the modes and mechanisms of action for both ultrasonic technologies, piezoelectric and magnetostrictive, focusing on frequency, amplitude, and power level. And then we also talked about the water lavage and how it has an impact on cavitation and acoustic microstreaming. We'll really focus more on diameter and shape of the tip of the insert, how those designs have an influence on the efficiency of deposit removal. So stay tuned for more information on that during our live sessions that are coming up. I thank you for your time and attention. Please feel free to email me with any questions. I have my email address here on the screen. It's simply gailmalone@dentsplyserona.com. I'll be happy to do my best to answer your questions. And I do look forward to connecting with you again during our hands-on session at the university. So thank you very much and have a good day.